Okay, so we hope during this session to find out what you think of the word CKD. Is it, do you really think about it as those patients who are doomed to develop end-stage renal disease, or you really think about it as those who will have irreversible kidney disease? And I'm sure Professor De Broe will have to say something about that. And then we'll have to cover points of when to start the preparation for renal replacement therapy, and what modality should we choose, and how to do that. So please.
Thank you. But we are together doing that, because I will not do alone. But after this very interesting starting session on the discussion of microproteinuria and all the nonsense around it, of course, there are some very fundamental correct things. Obviously, microproteinuria is a serious problem. But I just asked the permission to speak 6-7 minutes about something on the CKD classification. I had already some intervention yesterday, and I will start just by a study we finished in Morocco. And I did a presentation 48 hours ago. We had the Moroccan Society of Nephrology, but for the first time, they presented that study. It's a study on an epidemiological study on the, and you will see on what. It is a collaboration between, of course, the national government supported strongly the study after some time. The ISN did its best and gave us a small amount of money. The WHO was also doing a lot of good things. The Renal Society of Morocco and University of Antwerp together, we tried to do something. And I will just briefly, very quickly summarize what we have done. So this is Morocco, and we choose 2 cities. If you want to do an epidemiological study representative for the population, you have to think. It's a lot of thinking. So we decided to take 2 cities, 100,000, 144,000. This is an agricultural city, and this is a more industrialized study. So we took a sample, the population was that, and the population we wanted to study was between 26 and 70, because below 25 years of age, the prevalence and the incidence of renal disease is very low. You cannot do epidemiology on that. And what we did to have a randomized sample, what should you do to absolutely scientifically be sure that your sample is randomized? We used the voters list of these 2 cities. And if you have a voters list, you have the perfect screening of the whole adult population who can go to vote. The problem was in 2006-07 when we first got this voters list, and we checked everything what we did. We checked the voters list, and we went to 20 places in the city and nobody was there. It was wrong. The voters list was completely wrong. 50% of the list was completely wrong. So the voters list had to be restructured completely, and we had to wait 2 years. And after 2 years, finally, we got the voters list. And this was a correct voters list because we checked that. So we did a calculation for the sample size. We needed 5,000, 10,000 subjects, 5,000 in one city and 5,000 in this city, randomized according to the voters list to have a perfect randomized representative sample of this. And we were lucky because this is an aerial photograph of the city, and the French colonial people had installed in all the cities in Morocco, in all the colonies of France, small health centers. And there are 5 health centers in Kemiset and 5 in Al Jadida. And they are working with the 2 nurses, the doctor, the secretary, etc. We do the simple vaccination and baby care, etc., etc. So we get the permission of the government to use that personnel. Of course, the personnel was not able to do the study because they never used computers, they never used blood pressure, etc., etc. So it took us a long, long time before we could train them and get things done. So the first question was, will we have a good response rate? And for doing that, we trained the people. We had 19 official meetings over the two years of preparation, 10 seminars, 38 local visits. I went 38 times to all the places where we had to do the job, and 88 persons were implicated in that study. So this is a huge effort of all those very enthusiastic guys on the field, doctors, nurses, and secretaries. We also had one of my best collaborators is an artist in presenting science and presenting whatever you want in a scientific way. He can make a wonderful graph. And we make a booklet in French and in Arabic And we showed the people how to do. This is the midstream, how you have to do a midstream. So you cannot explain that in someone who cannot read, because 35% of the population of kidney set was non-illiterate, was unilliterate. So we used the design of the program, and all the acts, blood pressure, medicine, etc., were represented in that way, in order to understand what they will do when they come to the meeting. So the first visit was an interview, and then we did the different measurements, the weight. We standardized very carefully using these machines. In an absolutely standardized condition, we measured 3 times the blood pressure, and that was the final way of considering that as hypertension, yes or no. We did a fresh urinary sample with a dipstick, and then we used EMOQ for measurement of lower concentrations of albuminuria, and we did the glycemia and the creatinine. And in the second visit was 1 week after that. Everybody has to come back. When we found whatever anomaly, we did it again, and we controlled everything. We controlled the dipstick, we controlled microproteinuria, we controlled blood pressure, and we controlled the serum creatinine. I will go to show you the recruitment. Our goal was, this was the goal, the different groups we had to have. That was our goal. And you see the line, the black line is the goal. And the red and blue lines, males and females, or that was achieved in the different health centers. You see the different health centers did perfectly what they have to do. We had more than 95% response rate, positive response rate. This is very high, because normally the response rates for invitation to participate in epidemiological studies is lower, is 60-65%. But here we had a booklet. They had a visit of the nurse at home. They explained the program, and there was the promise, and in the meantime it is formalized, that they will follow for 5 years and get treatment for free, because if we find something, they will receive something. So the recruitment was excellent. I will not go over the results, just show you 2 of them, and then go to the discussion of the KDOQI guidelines. So the prevalence of hypertension is shown here in different age categories. The prevalence, the dramatic situation of the obesity in Morocco. Here you see this is the male body mass index is 11% more than 30, and 36% of the female population of Morocco has a BMI more than 36%, which in absolute is a catastrophe, because this is huge, huge, huge. If you use other criteria, hip-waist ratio, etc., you end up with almost 50% of the whole female population of Morocco has obesity. Here I come to my discussion. This is an overview of the KDOQI guidelines. The KDOQI guidelines says CKD 1 and 2, GFR below 90, etc. You know this, and 90 and 60. Then you can only consider a person to be CKD if he has albuminuria. So the GFR more than 60 is not, well, it's taken into account to separate the patients, but only those with albuminuria are considered to be being CKD. And that's something like 2 or 3%. And once you have CKD 3 to 4, below 60, there is no more condition of albuminuria. You have CKD, chronic kidney disease, as soon as you have a CKD below 60. So if you apply that, this is the still official CKD guidelines, and you look to the different studies, the big studies, it's a Jason American study, more than, I don't know, thousands and thousands of patients. You see the percentage of having a CKD 1, 2, 3, 4, 5 is 8.8 and 9.4 in some second time of the study. So that means that 90 million Americans have CKD, which is not negligible. The second study is Taiwan, and the population of Taiwan is 220 million. They found 11.9%, so more than 2 million Taiwanese. The Chinese want to do better, and they do very well apparently, but mainland China did a study on 150,000. They found 10%. So 140 million Chinese have kidney disease. I think the Chinese do well economically, but they have to do very well before they will treat this 140 million patients who became probably all CKD patients. And Maremar, the Moroccan study, found 8.3. So 2,480,000 were so-called CKD patients. Now I make a comment on that. What is the sense of that? What the nonsense of that? First of all, if you look to the different study and you ventilate the different stages, you see the percentages. Here the American study, and what you see, 2.2, 2.22, and you see, and if you look to this, you can immediately see a dramatic drop if you go from CKD 3 to CKD 4. Remember that, I'll come back to that. This is another study, a Norwegian study. This is again the United States study with Norwegian, a good study. And again, you see this exactly the same type of data, a small percentage, and then suddenly the drop once you have to go from CKD to CKD4. Here another, this is the first Chinese, the Taiwanese study, and again, and they have separated CKD3, even CKD2 and 2A and 2B, and CKD3 and 3A and 3B, whatever. But my message is for the moment that you see this fantastic drop, the dramatic drop from 6% to 0.10% if you go from stage 3 to 4. And here is the mainland China. And here is Maremar. This is our study, which we had in Morocco. And you see we divided them in GFR more than 90 and the different categories, and then microproteinuria and macroproteinuria, and you see here these are the numbers. So if you have subjects with macroproteinuria and with high risk of developing end-stage renal failure, it's only 1.8. But I come back to that to explain what I want to say. Here you see the all studies of the general population. This is our study. We published that in '87 in the Lancet, almost 30 years ago. Belgians, 12,000 Belgians. And you see, the point I want to make, this is Belgians. These are Europeans. These are Americans. This is Norwegians. And this, I don't know, I forgot. But you see immediately that according to the age and the sex, almost equal, but nevertheless a slight difference, there's a progressive decline in GFR in the normal population. A person of 70 years of age, and this is divided in percentiles. Percentile 50, which is the mean of a population, at 70, almost half of the population has a GFR of 60. So the whole normal population already has a GFR of below 60, becoming below 60, in the normal population. And you find it in Belgium, you find it in Europe, you find it in the United States, you find it everywhere, and we found it in Morocco. If you look to and you put on that this red surface, which is the surface of those below 60, you see that there is an enormous amount of the normal population having a GFR below 60. Or all those patients CKD patients? That's the definition. If you apply the definition to that, then you see this dramatic number of patients, of subjects having a GFR below 60. Just look to this. The difference, what is the difference between a young man of 35 years of age with a GFR of 60 is far below percentile 3. So he's just really a reduced, very dramatically reduced GFR. If this man, and probably this man, will have proteinuria, this guy has a renal disease. And you do exactly the same with a woman of 65 years of age, and you take this line of 60, she is on the percentile 50, and she has no proteinuria. So she's absolutely no CKD whatsoever. If you look to this, and you look to CKD 1, 2, 3, and you do the mean of all the studies I have found in the literature, substantial studies, good studies published, you see that the CKD3, almost the same percentage, 3%, etc., with a rather broad variation, but suddenly between 3 and 4, there is a dramatic drop. Meaning, the prevalence rate of stage 3 is many times more common than CKD 3, 4, 5, suggesting that stage 3 CKD is not simply a stage of evolution of CKD. It is a stage that seldom progresses to kidney failure. In itself, it shows that in CKD 3, the majority of patients never have any renal disease, because if they should have renal disease, they should progress to CKD 4 if you do a prevalence study in a population. Second point, of course, this has been discussed thoroughly nicely by the previous speaker. Once you have proteinuria, and your proteinuria is very well expressed and pronounced, that the 25-year incidence of end-stage renal failure goes up dramatically. Okay, we all know that. This has been shown. And here again, this is CKD 3 with and without proteinuria. If you have no proteinuria, you have exactly the same survival as a patient who have perfect normal renal function. So in the group of CKD 3, without proteinuria, the chance to have complications is almost negligible. As soon as you have proteinuria and hypertension, of course, your chance to develop cardiovascular events goes up dramatically. So the limitations of the CKD definitions are, that single absolute eGFR criterion, unadjusted for normal decline in GFR with age and sex, will lead to very high prevalence of false positive chronic kidney disease definition. A label put on the patient, on the subject, he does not deserve. You are never used for diagnosis and treatment. Second, eGFR below 60 without proteinuria are not at greater risk for of cardiovascular disease compared with eGFR greater than 60. The majority of living-related, in my country, I'm a member of the academy writing the rules for what we have to do for the select patients with living donation. The majority of living-related, non-related donors will be excluded if you use lower than 60 milliliters as a criterion of CKD. You lose your population for 50% of your donors because those have a GFR below 60. Association of decreased and declining GFR and increased risk of cardiovascular disease is steeper and more robust, of course, if GFR is less than 45 and in the presence of proteinuria. That has been clearly demonstrated. And then here, in stage 3, and remember that, stage 3 of CKD, representing 40 to 55% of the CKD population, calculated in all the studies I have presented you, the number that will progress to end-stage renal failure is estimated at only 0.1 to 0.2% per year over 10 to 15 years. The vast majority of these patients are younger than 60 years of age, those who go to end-stage renal failure. So the CKD3 group is for the majority a group of just aging patients. Some of them may be presenting some macroproteinuria, which they deserve, because of the context of vasculopathy of that age. This is from Glassock. Whatever early identification and treatment of subjects with reduced levels of eGFR within the normal range of their age, gender, but without any other manifestation of kidney disease, will reduce the subsequent risk of cardiovascular events or progression of renal disease is absolutely unproven. There is not a single study who ever did the study of CKD3 with some microproteinuria or without any proteinuria and follow up these guys and see if there is any protection for cardiovascular disease. It's not done. And I come back to the first slide. You see here all this beautiful population who is developing chronic kidney disease. And if you just count macroproteinuria in whatever stage of CKD, and GFR below 60 plus macroproteinuria, then you end up with 1.7% at the maximum in the population. So there's a dramatic difference of the CKD, serious chronic kidney disease. So what we want, what we need is more better things. And I like this, the concept of someone who is sitting in the audience, the cardio-kidney damage. There's also CKD. I like the comparison between the classical CKD classification. You can translate chronic kidney disease in cardio-kidney damage. And I like this concept, because the concept that chronic kidney disease in the elderly is merely a manifestation of a broader age-related diffuse vascular damage affecting a number of end organs, including the heart, kidney, brain. The question now is, did we have to treat aggressively those patients? That's a very important question. And also I agree with Glassock, who is proposing, and that's interesting to read for you, I will not go into detail that, he presents a new approach to do the CKD classification. Makes sense, make a lot of sense, based on clinical evidence, based on measurements, and based on very good things. So I think that's what I wanted to say.